Hello, everyone. Today I'll be presenting a critique of motivational interviewing at home, a community trial to improve oral health literacy and reduce morbidity in disadvantaged Chilean families by Cartez Velasquez and Luengo Machuca, published in the Journal of American Dental Association in 2024. This study addresses an important public health issue, early childhood caries, or ECC. ECC is one of the most common chronic diseases affecting young children worldwide. Although dental cavities are largely preventable, they continue to disproportionately affect children living in disadvantaged communities. Beyond pain and tooth loss, untreated caries can interfere with eating, sleeping, speech development, school attendance, and overall quality of life. Families also face financial burdens associated with treatment. One factor contributing to these disparities is low oral health literacy, which refers to a caregiver's ability to understand and use oral health information to make appropriate decisions for their children. Traditional education campaigns often increase knowledge but fail to create lasting behavioral change. Because of this, the researchers investigated whether motivational interviewing, a patient centered counseling technique that encourages individuals to identify their own motivations for change, could improve oral health outcomes when delivered through home visits. The goal is to determine whether home-based motivational interviewing could improve oral health outcomes and oral health literacy after 12 months in disadvantaged Chilean families. The researchers used a cluster randomized, single-blinded community trial. Communities, rather than individual families, were assigned to intervention or control groups to reduce contamination between participants. Clinical examiners were blinded to group assignments, helping reduce measurement bias. This design was appropriate because it evaluated the intervention in a real-world community setting. The study included children aged 2 to 4 years and their primary caregivers from disadvantaged Chilean communities. Families in the intervention group received 4 to 6 home visits from trained dental hygienists using motivational interviewing to help caregivers identify barriers and build healthier oral hygiene habits. Researchers measured dental caries using ICDAS oral hygiene with the Oral Hygiene Index and oral health literacy using OHLI and REALD 30. Data was collected at baseline and after 12 months, then analyzed using t-tests, univariate analysis, and ANCOVA. The findings were mixed, but still clinically meaningful. The intervention produced a statistically significant reduction in early-stage dental caries, specifically lesions identified with ICDAS scores greater than 0. The reported p-value of 0.03 indicates that this improvement was unlikely to have occurred by chance. However, the intervention did not significantly reduce more advanced dental caries, defined as ICDAS scores greater than 2. Likewise, there was no statistically significant improvement in overall oral hygiene, with a p-value of 0.74. When evaluating oral health literacy, the researchers observed only minimal improvement. Scores on the REAL-D30 assessment increased slightly, while broader measures of oral health literacy did not demonstrate meaningful changes. Overall, these findings only partially supported the researchers' original hypotheses. Motivational interviewing appeared to help prevent the development of early disease, but it was less effective at reversing more advanced disease or producing substantial improvement in oral hygiene behaviors and health literacy. These results also reinforce an important public health principle. Behavioral interventions often require sustained reinforcement and may work best when implemented before disease becomes established. This study has several methodological strengths. First, its greatest strength is its high ecological validity. Because the intervention occurred within participants' homes and communities, the findings are more representative of how similar programs would function in actual public health practice. Second, the researchers used standardized and internationally recognized measurement tools such as ICDAS, improving consistency and reliability across clinical assessments. Another strength was the rigorous training provided to dental hygienists delivering the intervention, helping ensure that motivational interviewing techniques were applied consistently throughout the study. Despite these strengths, there were several important limitations. Participant attrition over the 12-month follow-up could have introduced bias if families who dropped out differed from those who completed the study. There is also the possibility of self-selection bias, since families willing to participate may have already been more motivated to improve their children's oral health than non-participants. Additionally, community level interventions are inherently difficult to control because outside influences, such as access to dental services, nutrition programs, or socioeconomic changes, may have affected outcomes independently of the intervention. Finally, while the study demonstrates good internal validity due to randomization and blinded outcome assessment, its generalizability is strongest for disadvantaged Latin American communities. The findings may not directly apply to populations with different healthcare systems, cultural practices, or socioeconomic conditions. This study shows that motivational interviewing can produce modest but meaningful reductions in early childhood caries. It also highlights that early intervention, caregiver education, and continued home-based support may be more effective than simply providing information. Starting prevention before age 2 may offer the greatest benefit. Overall, while the intervention did not improve every outcome, it provides valuable evidence that community-based behavioral approaches can help reduce oral health disparities. Thank you.